Okay, thank you very much. Good afternoon, everyone. It's a pleasure for me to participate this year in your course. Good afternoon, and thank you for the invitation. So I'm going to talk about endovascular management of benign prostatic artery, benign prostatic hyperplasia. So these are my conflicts of interest. Next slide, please. So I'm going to talk about anatomy, first point. Next. Next. Technical obstacles of prostatic artery embolization, inclusion and exclusion criteria, results and conclusions. Next slide, please. Next. So this is what anatomy books tell us. Next slide. Next. So this is what anatomy books tell us, that the prostatic artery comes from the anterior branch of the internal iliac artery, and we have the main prostatic artery origins, but we know that it's not always like this. Next. So sometimes not so clear. Next slide. So there are a lot of arteries in the pelvis. Next. So we have the anterior and posterior branches of the internal iliac artery that have many variations. And we have the vesical arteries, the rectal, the obturator, accessory pudendals, differential, spermatic arteries, and we still have anastomosis, a lot of anastomosis, and tortuosity of the arteries. Next. And never forget, we can have very, very different anatomy, very different prostatic artery origins. Next. So here, another important aspect of the vascular anatomy of the prostate is the accessory pudendal artery that can occur in about 20 to 30% of patients, and this is another pudendal artery that can have a close relationship with the prostatic artery. Next. So here you find the first picture. You have a selective angiogram with still the dorsal artery of the penis, and on your end side you see a selective angiogram where you can see number 1 is an accessory pudendal artery, the 2 is the pudendal artery, and the 4 is the distal branch of the accessory pudendal artery. So it's a very huge accessory pudendal artery. Next. Next. So we can have one artery, we can have 2 independent branches, one anterior lateral and one posterolateral, and these are the most common origins of the prostatic artery. For internal pudendal artery, from the spirovesical, gluteal pudendal trunk, and obturator artery, these are the 4 most common origins of the prostatic artery, and we have some uncommon origins, like the common trunk with the rectal branches, especially the posterolateral branch of the artery, and also the inferior gluteal artery. Next. And we still have some other very, very different rare origins. Back. So we can have from the accessory pudendal artery, from the superior gluteal artery, and we had some cases of a prostatic artery coming from the obturator, but coming from the epigastric. So it means the external iliac artery. That is a very, very different anatomy. Next. So when we have an anterolateral branch and a posterolateral branch independently, normally the anterior branch has a more proximal origin and has a close relationship with the vesical arteries, and the posterolateral branch has a close relationship with the rectal arteries, with the anastomosis, with the rectal branches, and normally has a more distal origin in the pudendal artery. Next. So we can have one patient, 2 pelvic sides, and 2 different prostatic arteries in each patient. That is very, very usual. Next. So here, just some cases, just to show you the different anatomy that you can find. So in this case, the right prostatic coming from the obturator artery. You see on the DSA image, the obturator artery there, it's the more the first artery coming, and then you have the prostatic artery with the corkscrew and a lot of tortuosity. That's the prostatic artery coming from the obturator artery. Next slide. So here another case, better the same case on left side, we have a prostatic artery coming from the inferior gluteal. It's not very common. We see on the first picture, DSA, the prostatic artery with a very tortuous artery coming from the inferior gluteal artery. And on the third picture, on your right-hand side, you will see a selective angiogram of the prostatic artery, and you can see very big anastomosis, contralateral anastomosis. Next slide. So this is another case with two independent prostatic branches that is also common. And we see on your left side, you see two different prostatic branches coming from the vesicoprostatic trunk. So also common with the vesical arteries. That is a very important anatomy because we have to avoid the vesical arteries to embolize. And on your right-hand side is the post-embolization control with the complete devascularization of the prostate on the right side. Next slide. So here again, a better picture on your left-hand side. You see number one is the prostatic artery, and 1A and 1B are respectively the anterior or cranial prostatic artery, and B is the posterolateral prostatic artery. And you see in the middle, you see selective angiogram with almost complete opacification of the prostate, and on your right-hand side, the control post-embolization with occlusion of the prostatic arteries on its side. Next. So we always do CTA before embolization to study the anatomy of the patients. That is very important because of the anatomical variations. So we think that with the CTA, we can reduce radiation during the procedure. Of course, the procedure time, contrast, we don't get lost during the procedure. And normally, ultimately, you will reduce our complications. Next slide. So this is just an example of a CTA, MIP reconstruction. You can see very well even the intraprostatic vascular supply. So we can study very well not only the prostatic artery origin, but also the intraprostatic circulation. Next. So concerning anastomosis, it's also very important because we need to avoid completely non-target embolization to bladder and rectum and penis. So there are the three main organs that we have to avoid at all costs. Next slide. So we have anastomosis in more than half the patients. Next. Next. So the most important anastomoses are ipsilateral and contralateral. So normally there's no problem to embolize because we are in the prostate. Next. So no problem. Next. But we have some other anastomoses. So beware of anastomosis with internal pudendal artery and the risk of venous ischemia, vesicle arteries, accessory pudendal arteries, and rectal arteries. It's the four main anastomoses after the prostate. Next slide. So here, just some examples of a very big anastomosis with internal pudendal artery, and of course the risk of venous ischemia if non-target embolization is performed. Next slide. So this is another very bad anastomosis with the rectals and the reflexive filling of the inferior mesenteric artery, as you can see very well on the left picture. Next slide. And we also can study the tortuosity and plan our procedure. If we go from the right on the left side, if we use a short or long sheath, or what kind of microcatheter we're going to use in each specific case. Next. Next. Yeah. So this is a video just to show you how we do. So normally we use a Roberts uterine catheter. There is a Rook catheter specially designed for the uterine arteries. So we do a lot of UFE with this catheter too. So what we do is we do the crossover with the unilateral femoral puncture, and after the crossover we do Waltman loop. After the Waltman loop, what we do is to try to catheterize the anterior branch of the internal iliac artery. So here you see on the video, you see the tip of the catheter trying to reach the anterior branch of the internal iliac artery. So after that, we do our first angiogram and we compare with the anatomy that we found at the CTA. And you can see here the first angiogram now, just to study the vascular anatomy. So you have the superior gluteal, inferior gluteal, and internal pudendal artery, the three main arteries. Then we have the obturator. And then we do a roadmap. And with the microcatheter, we try to go selectively, as you can see here. And then we do our first selective angiogram. So you can see the microcatheter just advancing now. And we try to go as distal as possible to have a very selective DSA and to avoid non-target embolization, to exclude completely the vesical arteries, the rectal arteries, and of course the branches of the internal pudendal. So this is our first selective angiogram. As you can see on the right side, very nice prostate, ossified. And with this point, we are safe to embolize. So here is our first control, still with some vascularization in the prostate. And this is the final control with complete devascularization of the prostate on the right side. So we do bilateral, of course, not the puncture, I mean the embolization. Next slide. There are some technical obstacles although. Next. So we can have spasm because we are talking about arteries, very, very small arteries, very thin. Dissection is also very common. Artery dimension, because it limits feasibility, of course, because we are talking about arteries with about 1.82 millimeters in diameter. Next slide. Extreme vascular tortuosity. Next. Next. So our endpoint is near stasis, complete devascularization of the prostate. And of course, we have to avoid at all costs non-target embolization in these cases. Next. Sometimes it's not possible to catheterize also. We had some cases that it's not possible to catheterize. Next. Next. So this is what we normally use, our materials. So we use a rubber suturing catheter normally, and a microcatheter ranging from 2.0 French to 2.7 French. Normally we use a 2.0 French pro-grade catheter with the GT guide wire, but you can use any other micro catheters. Embolic agents, we normally use PVA ranging from 100 to 300 micrometers, and Ambosine from 250 to 400 because we're talking about microspheres in this case. So we have to upsize a little bit. Not to avoid non-target embolization. Sometimes we have to embolize with a microcoil to avoid non-target embolization, especially with the rectal arteries. Next slide. And the endpoint is new stasis in prostatic vessels and arterial flow interruption. Next. So in conclusion, technical aspects, we have to use very small particles to reach microvascularization of the prostate, and of course we should be aware of anastomosis. Next. Sometimes it's not very easy even to catheterize the internal leak artery because we are talking about some of them are very old patients. So we have to be careful in these patients. Next. So this is the microcatheters we normally use. Next. And I'm going to talk a little bit about our inclusion and exclusion criteria. Next slide. So the critical evaluation is very important before the embolization. So we assess the severity of the low urinary tract symptoms by the IPSS. There is an international validated questionnaire. That's the International Prostate Symptom Score. Then we evaluate also the quality of life of our patients. The call question, that is an additional question after the Lutz questionnaire. And of course, we assess sexual function before and after the embolization with the validated questionnaire. There is the IIEF, the International Index of Erectile Function. Next slide. Uroflowmetry also in all patients to assess the maximum flow rate and post-void residual volume. And the digital rectal examination and the transrectal ultrasound is also performed by our urologists and by also radiologists. And the PSA is also measured to try to exclude cancer and in case that we need the biopsy before the embolization. Next slide. So first we have to understand also what is BPH, what is available from medical therapy to surgical therapy, and we have to know the guidelines of the treatment of these patients. Next slide. So this is the diagram of the evaluation from the guidelines, the European guidelines, and we do pretty much the same before the treatment of the lower urinary tract symptoms. Next. So this is just to show you what is the IPSS score. So you have 7 questions, and then you have some points at the end. The sum of the points represents the severity of the lower urinary tract symptoms. And you can see on the right side, from 1 to 7, we have mild symptoms, 8 to 19, moderate symptoms, and 20 to 35, severe symptoms. And then at the end of the questionnaire, you have an additional question. That is the question, the quality of life of the patient. Next slide. So our inclusion criteria are patients over 50 years old, with prostate over 40 grams, with established diagnosis of BPH with moderate to severe flutes, and that are not responding to medical therapy for at least 6 months, with sexual dysfunction or accepting that risk, and one of the following: an IPSS superior to 18, or a quality of life superior to 3, and a peak urinary flow inferior to 12 mils per second, or if there are an acute urinary retention. There is also another group that are patients with very big prostate and contraindication for anesthesiology. Next slide. So exclusion criteria, we exclude very little patients with severe atherosclerosis and tortuosity, so it's about less than 5%. Non-visualization of all prostatic arteries on angio-CT is a relative contraindication, and the complete contraindications are malignancy, detrusor failure, neurogenic bladder, diverticulums or stones, and urethral stenosis or other urethral pathology. Next. Next. So we are going to talk a little bit about results. Next. So the possible complications of this procedure are cranial, urethral, and retroperitoneal pain, diarrhea, rectal bleeding, infection, bladder, ischemia, hematuria, hematospermia, planitis. These are the possible complications. We didn't have all of them. Next. So in more than 400 cases now performed, that the major complication was the whole ischemia. So you can find on your left-hand side, you see that was the case that I showed you, that was artery coming from the obturator artery before. And we saw retrospectively that we had some anastomosis with vesical arteries there on the third picture, the SA picture. You see very big anastomosis with the vesical arteries, and the patient had pain during the procedure, and there was a very big complication. Next slide. So it was a urological intervention that removed part of the endoscopically part of the mucosa that was necrotic. So these are our results. This is what we do. It's clinical history. It says the severity of LUTS, the quality of life, sexual function, uroflowmetry, digital examination, ultrasounds, and MRIs. Not in all cases, in most of the cases now. And we assessed our minor and major complications. Next slide. So these are our last results published in European Radiology online now, with more than 250 patients now with follow-up. Technical success of 98%. That means that we embolized at least one prostatic artery, but in the large majority of cases, we embolized both sides of the prostatic artery. So more than 50% of anastomosis with other pelvic organs, and 88 patients were treated as outpatients. Next. So this is our definition of clinical failure or poor outcome. And we have poor outcome when we have one criteria of this. So an IPSS superior to 20, or a reduction inferior to 25%, a quality of life superior to 3 points, and or reduction at least 1 point, or less than 1 point, sorry. a Tmax improvement inferior to 2.5 mils per second, and if the patient needs additional treatments like surgery or continue medical therapy for a long time. Next. So this just to show you on your right-hand side table with the mean value of the IPSS decreasing, as well the quality of life, that is improvement of quality of life when we decrease the points. And we didn't have a lot of success with the Kmax because the improvement was not very significant in terms of mils per second, although it has statistically significant results. Next. So just to show you the clinical improvement over time. So we have from 1 month to 36 months. So we have in about 80% to 72% at 3 years follow-up, even though we still have 8 patients with the 3-year follow-up in this study. Next. So in conclusion, it's a promising future endovascular technique. It's a minimal invasive that can have a place in the guidelines as a minimal invasive procedure. It is essential to know not only what is BPH and the clinical characteristics of the disease, but also to study the prostatic anatomy. The vascular anatomy of the prostate is very important to embolize the prostate. Next. So tortuosity in atherosclerosis limits visibility. Small anastomosis can be undetected with conventional angiography and no significant post-embolization symptoms. So we don't have a lot of post-embolization syndrome, although potential serious complications can occur after non-target embolization. Next. Thank you very much for your attention. Thank you.
Hello, I'm Vipin Arora, one of the urologists. It's a very impressive presentation, to be honest. First time I've ever been exposed to this procedure. This totally puts the teaching we had, means many years ago, that acute retention of urine is something like an infarction of the prostate. That why suddenly one day patient is passing urine and suddenly he develops retention. The theory proposed at that time, I'm talking about good 20 years ago, is it's like an infarction of the prostate. So that infarction produced edema and produced retention. We used to catheterize, wait for a few days, remove the catheter and have a good flow of urine without doing any procedure. Now you're talking about is creating an infarction in a patient who may not be in retention. So do you see retention of urine as a post-op or post-embolization outcome? And what percentage did your series have?
So normally in patients that are not under retention, we don't have any case of retention after the embolization. We have sometimes that's difficult to avoid after embolization. In some cases, we place a Foley, but it's removed some hours after the procedure. But not in all cases, just in some cases that they have difficulty to avoid. In patients with obstruction or with urinary retention, what we normally do is we don't remove the catheter right after the embolization because the inflammatory process. So what we do is after the embolization, they continue the medication that we give, especially anti-inflammatory drugs and antibiotic with ciprofloxacin, and we wait at least 10 days after the embolization to try to remove the catheter, because otherwise, because of the inflammation, we risk of keeping the catheter inside for a much longer time.
Thank you. Any other question?
Is there a risk of accidental bladder necrosis if you get into a non-target vessel? I think you showed one case which was
Yes.
almost like a bladder infarct.
Yes, there is a risk, of course, because we have a lot of branches to the bladder. Sometimes we see them very well because they have very close relationship with the prostatic arteries, especially the anterolateral branch. So we have to avoid at all costs this artery. Normally it's not that difficult, so we have to advance our microcatheter as distal as possible to avoid all branches to the bladder, but it's a potential complication, of course, and we had one case. It was our case number 10, actually. It was about 3 years ago, and it was a very big complication for us because we are not very familiar still with the procedure. But of course, you have always the risk of bladder ischemia and rectal ischemia and penis ischemia if you are embolizing branches that go to the bladder, rectum, and internal pudendal respectively.
Yeah,
Dr. Hugo, you've done this study in benign hyperplasia.
Yes.
Are you aware of any such study for CA prostate early stages or something like that? Embolization in CA prostate or something, early stages or something like that. Are you
You're
aware of
asking
any
about
such-
prostatic?
You've done the
Cancer
study in benign hyperplasia of prostate.
Yes.
Are you aware of, or have you done anything like that, embolization in CA prostate, carcinoma of prostate or something?
Cancer? No, never. We
Or are you aware of
we
any
are
such study?
just with benign prostatic hyperplasia, not prostatic cancer. So we're not embolizing any prostatic cancer, and we don't know if it's a possible technique in the future to do that. But for this moment, we are doing just for benign adenoma. Yes.
Just to carry on that, your slide showed that there was a range of PSA from 0 to 58. We are very,
Yes.
very skeptical in doing anything above 10 because that is almost certainly to rule out
Yes.
the CA prostate. Did you do biopsies above 4 in all the cases?
Yes,
Any
all
procedure
cases. Yeah, all cases above 4, we do in all cases biopsy before the procedure. If it's positive, it's contraindication. If it's negative, we can do the embolization. Of course, in the middle of those group of patients, even with a negative biopsy, we don't know because we are never sure about prostatic cancer in some patients, of course. So we do with the negative biopsy, but of course there are probably I don't know, some patients that have any cancer that was not detected at the time. So we know that it's completely impossible to exclude completely a prostatic cancer in those kinds of patients. But we don't do in any positive biopsy, of course. No.
Yeah, the PSA of 58, I think you might inadvertently have embolized CA prostate because 58 is too high.
Yeah, no, we don't embolize without a negative biopsy in all those cases. Definitely not. And we also perform MRI, so we study the patient before the embolization, of course.
How do you select your patient? I mean, how do you get a referral? Is the urologist who send you patients for the procedure, or it's like they come on their own?
So in the beginning, we work with the urology team. So that's the chairman of urology in our university. So in the beginning, we had patients from urologists. Now what is happening now is the patients, because they know already the procedure, they come directly to us, and then we send them to the urology, and the urology send them to us. So it's a different circuit now, but they all have urological evaluation before embolization, of course.
What is the average procedure time?
So in the beginning, there was about 2 to 3 hours. It was a very long procedure. Now we can do it in average in about 1 hour, maximum 1 hour 15. So.
Yeah, question.
Yeah, I have 2 questions. One is it a prostate has got an outer portion and the inner portion where the hypertrophy occurs, and which is removed in prostatectomy. So which portion of the prostate regresses most after this embolization, whether it is the outer portion is ever affected or it is not affected? That's the one question. The other one was that, as another colleague had asked about prostatic cancer, in very early stages, when the prostate can regress, why not we use this technique for prostatic cancers? Because if there is a person who hasn't got any metastasis outside, and if we damage the source, then the possibility of metastasis is decreased, and the prognosis improves in patients of prostate cancer? These are the questions.
Thank you very much. This is a very important question, actually, because we are dealing with benign prostatic hyperplasia, so we are talking mainly with the central and transitional zone, of course. And so, as I told you during the lecture, there are two different prostatic branches that can be independent or from the main prostatic artery, one anterior and one posterior, or if you want, one cranial and one caudal. And we know that the anterolateral branch goes to the central part of the gland, and the posterolateral branch goes to the peripheral of the gland. So our main goal is also to always to embolize the anterolateral branch, that means the central and transitional part of the gland, and not really the posterior, the posterolateral branch, it means the peripheral prostate, for two main reasons. One reason is that the BPH is more in the central part of the gland, so the adenoma is not in the peripheral part of the gland, and we are treating BPH, we are treating the symptoms of BPH, and the peripheral prostate that is vascularized from the posterolateral branch doesn't have normally a very rich vascularization and has a very close relationship with the rectal branches. Sometimes very difficult to go selectively, very difficult, and it's not that important because we are dealing with peripheral. So what our goal is always to embolize the anterolateral branch. It means the central part of the gland because we are dealing with BPH.
How much?
And the second question about prostatic cancer, I think that probably in the future it will probably have a role in prostatic cancer, this technique, because it's a technique of selective catheterization of the prostatic arteries. So I think it's a technique that has a role in the prostatic cancer treatment in the future. But now there are no studies, even in animals, considering this. So I think it's very early to begin a study in these specific patients.
There is another problem because the prostate cancers are usually located in the outside, which you said is difficult to ablate. And while there are only few patients in which borderline zone, that is also affected by prostate cancer. So possibly in these cases only this technique may be effective. I want to ask as to how much regression in the size of prostate you have noticed after this treatment? From the previous, suppose it was 40 grams, as you said, and what was the weight after the treatment, and how much time, whether it was constant or it increased after some time?
Yes, we embolized prostate. In the beginning, we started with prostate, very large prostates, of course, and I think that the better results when we have prostates over 100 grams, because the reduction and are much significant, and of course the lower urinary tract symptoms are very severe in those patients, and we can change a lot the quality of life of these patients. But we know that the prostatic volume reduction is not a predictive factor of clinical outcome now. So for us it's not that important because we have patients that didn't have reduction of the prostatic volume, but they had improvements, and other patients that reduced a lot the prostatic volume that they didn't improve. So we know now from our data that it's not a predictive factor of good clinical outcome, and we now think that the prostatic volume is not that important. Although I can tell you that the prostate reduction in between 6 and 1 year, it's in about 30 to 40% of the total volume measured before embolization. But again, it's probably not very good criteria to establish clinical outcome of these patients.
Thank you very much, Dr. Tinto. We really wanted to discuss more, but because of paucity of time, we have to close here. Maybe next year we see you here in India.
Thank you very much. Thank you very much.